We're going to talk about bacteremia today. And this is the first time I'm giving this lecture, so hopefully it will go well. And I think going forward, I think it might be fun to actually do some question answer thing. But as of today, what we have is kind of straightforward. So when we talk about bacteremia, the key things, what we're going to discuss is the organism itself, which I think you're all familiar with most of the names of the bacteria. And of course, what's important is how many blood cultures are positive and time to positivity. And we are also, now I can't see my slide. Yeah, thank you. The pattern of bacteremia, whether it's intermittent or continuous, because that tells us a lot about what the complications may be. I think a lot of you ask when we need to follow up blood cultures, so we'll address that. And then we'll look at some specific organisms in terms of how we evaluate their risk for complications and how to treat them. So thank you. Next. So first off, this is just a list which I think you're kind of familiar with, as the first group are the ones that should always be considered significant. And I think you recognize that most of these are pathogens. I think the last two, Bacteroides and Candida, I think maybe Bacteroides is underappreciated, and Candida, I think now we are pretty cognizant of the fact that it is a pathogen and has to be taken seriously, mostly because nowadays we have so many more immunocompromised patients and we're using so many more catheters, but they're not to be dismissed. The middle group, which is Enterococci and Strep viridans, are also kind of undergoing a change. Enterococci was always historically thought to be not very pathogenic. And even still, there are some clinicians that if they see one blood culture, one bottle may not treat if the patient is clinically well. But it is increasingly recognized as a problem as we have an aging population. And in fact, it is now, if it's community acquired enterococcal bacteremia with no focal findings, it is one of the Duke's criteria, major criteria for endocarditis. And Clostridium is another one that you have to kind of judge what the clinical picture is, whether it's real or a contaminant. And then the last category are almost always contaminants. So coag-negative staph, carini, and Cutibacterium, which used to be Propionibacterium, is almost always in the blood a contaminant, but in shoulder surgery may be real. But we're talking bacteremia. So in general, these latter are almost always contaminants. So next slide. So the patterns of bacteremia, I think the way I like to think about it is it's either intermittent or continuous. And basically intermittent is kind of what we always associate, that there is a localized exam or a focus of infection. So it's the kind of bacteremia that we're more often familiar with. So either there's a skin and soft tissue infection, there's bone or joint involvement, there's a pneumonia, the biliary tract or the urinary tract is involved. So that's the more common scenario. And again, it can also follow manipulation of infected tissue. So if you're doing an IND of an abscess, or if you're getting dental work or doing a procedure where you're biopsying, there may be a transient bacteremia. So that's the more usual. And the thing that's important is that if you can, control that source, you will then resolve the bacteremia. And that will get us to the when do you follow up blood cultures. And the second pattern of bacteremia is the continuous. And that kind of is the definition of endocarditis. And it reflects the presence of a persistent endovascular focus. So that is a deep-seated infection where If we do not surgically remove the graft or the catheter or the vegetation or the graft, then you will have positive blood cultures all the time. So it doesn't come and go, it is continuous. Okay. So this is kind of a lead-in for our major pathogen, and the one for which repeat blood cultures is always indicated. So the Staph aureus has a lot of factors: its virulence, its ability to cause or create biofilm. It's associated, therefore, with endovascular infection, and it is critical to achieve source control so that we can clear the infection. And in Staph aureus bacteremia, you always have to obtain a follow-up blood culture. And sometimes we even do what are called skip cultures. So you'll have day one, you do your blood cultures, it's positive. Day 2 or 3, you repeat and it's negative. And then we may ask you to do it again on day 4 or 5 to confirm that it stays negative, because sometimes the blood cultures don't have enough blood. You may actually not pick up a very low level of bacteremia, and we want to be sure that we have a negative blood culture. And I referenced here 2 articles which really kind of support the notion that for most gram negatives and even streptococcal bacteremias, there is there is really no role for repeat blood cultures. The likelihood of still culturing something when the patient has responded is really very, very low, like 1.5%. When it is a problem, when the patient still has fever, it's usually indicative of a lack of source control. So you haven't, drained, cholangitis, or you haven't removed a catheter. And probably getting a CAT scan, or let's say in pyloid, there may be the development of an abscess. So probably getting a CAT scan would be more helpful than repeating the blood cultures. So really, the reason, we'll go over this again when we talk about gram-negative bacteremias, but really you don't need to do it for most gram-negatives and strep infections. So this is kind of just to reinforce what we said. When to follow up blood cultures, really it's for staph. So Staph aureus is our number one. Staph lugudensis, just so you remember the name, is pretty much, it's a coag negative staph, but it acts like Staph aureus. So that one you should be familiar with, and Candida, which we're really not going to focus in on. And the times when you really worry the most is when they have, when you do suspect endovascular infection. So if you think they've got endocarditis or graft infection or so on, or if they're highly at risk for developing such. So if they happen to have an ICD in them, or if they are dialysis with a vascular graft, or they've had a history of a prosthetic valve, then these people should be, maybe should have repeat blood cultures. Then the usual, which is if they're sick, so if they've got fever or a white count, even after 72 hours, then you could consider it. But again, in the gram-negative and strep infections, it's more likely the reason that they're still sick is because you don't have source control, or they've developed an abscess. The other times to get a repeat blood culture is if you happen to know that whatever you isolated originally is, very resistant and difficult to treat. So then maybe your antibiotics are not penetrating the space well. And again, for an unknown source, which is kind of the definition of endocarditis or an endovascular infection, if you don't have a localizing finding, then they very well may have an endovascular focus. So that would be the case. You'd want to repeat and make sure that they've cleared it. So next slide. The reason that we are so worried about Staph aureus bacteremia, I think, is nicely illustrated here. So in this study, what they looked at is, if the blood cultures are positive on day 1 or 2, only 6% of people actually have a complication. But if the blood cultures remain positive on day 3, the incidence of complication increases to 24%, which is significant. So that's why that day 3 blood culture is really so critical for us. So when we ask for repeat blood cultures, that day makes a huge difference. Day 3 to day 4, you really jump in terms of the risk for developing a worse outcome and having metastatic complications wherever that may be. Okay. So, what is a complicated Staph aureus bacteremia? So, when it's simple, which is uncomplicated, you have a bacteremia, you remove the focus, or you drain the abscess, take out the catheter, whatever, they clear their bacteremia, they do well. What is a deep focus of infection? The one that we worry about is infective endocarditis. That occurs in about 12%. So it's not a huge number. It's just a horrible disease. So that is why we're so concerned about it. But there are other complications. It doesn't all have to be endocarditis. And the reality is many of our patients now have some kind of device or prosthesis. So they could have a cardiac device infection. It would be rare for the cardiac device infection to be infected without endocarditis, but that could happen. The osteomyelitis most commonly is vertebral. Obviously, if you have even a long-standing prior joint replacement, that can get infected from a transient bacteremia, and it doesn't have to mean it was endocarditis. You can get septic arthritis, meningitis, and pneumonia. So then the question becomes, these are the complications. So how do we identify which patients are at risk? And these two names are probably, Holland and Fowler are probably the two biggest names in Staph aureus infection. Holland does a lot of the work on antimicrobial sensitivities. When do you use 2 drugs? Does it help? And Fowler has done all the work on the Duke's criteria using echoes. And basically, over the years, they and many others have tried to figure out what characteristics are associated with a low risk of endocarditis, and who do you need to worry about. And this is an up-to-date also, and it's an excellent chapter, the Staph aureus bacteremia chapter. And essentially, if you don't have an intracardiac device, if you clear the bacteremia within 72 hours, 4 days, if you're not on dialysis, and if it's nosocomially acquired, which means really that when they got it, so you can kind of have a sense of how long they might have been sick. So it's when the IV was became infected. And if they don't have any secondary foci of infection that are obvious or clinical signs of infective endocarditis, these patients should get a TTE, but probably are at low risk for endocarditis, so you probably don't need to get a TEE. Okay. So here is a scoring system. So if you like algorithms, this is Fowler again, and it's the Versta score, and basically has some of the things that we just mentioned, trying to help you decide who you should send for a TEE or not. And the criteria primarily are what we said. A prolonged or a persistent bacteremia with one of the following on the left is, meningitis, some evidence of a complication, and or the others, which we mentioned, vertebral osteo, community or non-nosocomial acquired, and obviously severe illness, shock, or they have, this is the only scoring system that uses a CRP. So a CRP of greater than 190. And if you have any of these things with a score totaling more than 3, then they recommend that you get a TEE. So there's a low threshold to get a TEE, but these are kind of helpful. And the next slide is called the PREDICT score. And Larry Badur, who does a lot of our guidelines for any kind of like the AHA guidelines for endocarditis, so he's a big name in guidelines. He's basically also telling you, if you have community acquired or any prosthetic device, get a TEE. And this one is simple, and then, you know, reassess them several days later. If they're still positive bacteremia, get a TEE. So I think this one is quite useful and quite straightforward. Okay. So I know I'm beating a dead horse, but it's always interesting how many times I can say it and I still look it up. So when, you know, you've got a Staph aureus bacteremia, everybody gets a TTE. Who do you get a TEE and who do you worry about more? The major problem is if their bacteremia is persistent. If you don't know how long they've been infected, so if they're coming in from the community, they could have been sick for a week before they came to you, they should probably get a TEE. Any kind of prosthetic material, any predisposing valvular abnormality, then they should get a TEE. And if they don't have a source, that makes it more worrisome. Dialysis patients are always immunocompromised, and they've got a lot of atherosclerosis. They've almost all got valvular disease. So basically, and they all have catheters, right? So they're the highest risk patients. So they all should get a TEE. And anybody who has evidence of extracardiac involvement, like osteomyelitis, which is a common landing place for the bacteremia, or any other stigmata of endocarditis, they should get a TEE. And we should not forget the IVDU patient, because although we associate it with right-sided and the TTE sees that very, very well, about 20% of IVDUs have concomitant left-sided endocarditis. So don't forget that. Okay. And yet again, just to let you know, there've been all sorts of studies because our patients now really do have a lot of prosthetic devices, to tell you that we worry about Staph aureus bacteremia because there is a high incidence of complication. So the cutoff time, just to go back, I see a question. So generally speaking, we say 72 hours. If they're persistently bacteremic, maybe that's not your question. If they're persistently bacteremic for more than 72 hours, they get it. If they're persistently bacteremic, and some of our dialysis patients can be persistently bacteremic for, you know, we've had cases where they're bacteremic for up to 2 weeks, they can still get a TE, because anytime along that line, they could develop a vegetation that you could see. In general, the best time to get a TE is within the first 5 to 7 or 8 days. After that, the yield goes down because you might have either flipped the embolus, or it may be actually improving on treatment. But if you have a high index of suspicion, you should repeat the TE, even if it were negative at the first time. So if you got a TE on day 3 or 4 and it's negative, but you're worried, you can repeat the TE the following week. So again, it's clinical. It's not often that we have to do that, but I would say that the outer limit is really based on the clinical scenario, although I would imagine by about day 10 or 12, it's it would be gone, or it would not be useful unless obviously the patient wasn't doing well. So here I just wanted to show you, I'm sure you've looked at it now, but the arthroplasty, prosthetic valves, pacemakers, central lines. I mean, look at these incidents of complications. So I think it's really important that we appreciate how significant a problem Staph aureus bacteremia can be. Okay. This is one of my, I think, most useful charts. It's also Fowler, Holland and Fowler. So it's a good algorithm, and the top half it's a little busy, so I hope you can see it well, but it's for Staph aureus bacteremia. So if it's an uncomplicated infection, they defervesce, the echo is negative, they don't have any signs or symptoms of metastatic infection, they don't have devices, or you pull out the line within a short period of their admission, then 2 weeks is enough. If it's complicated, then we're looking at 4 to 6 weeks. And I think because I don't actually have a separate slide for coag negative staph, but I think this is very useful because a lot of times we get the consults for coag negative staph. And what they recommend here, they define it as simple, which is just a single positive blood culture without really any symptoms or signs. Really, you don't have to treat them at all. Most people end up getting a couple of days until you get the preliminary blood culture report back. But essentially, those don't need to be treated if it's just one blood culture bottle. But they call uncomplicated more than 2 bottles drawn within the first 24 hours with signs at a catheter site. So if you take out the catheter, you can just treat them with a short course of 5 days. And then complicated is more than 2 blood cultures drawn greater than 24 hours apart, either with an echo or signs and symptoms of metastatic disease. And then they basically get at least a month treatment. Although the range is variable. I think most people, if they really thought it was significant, would treat for a 4-week course. So that's a nice algorithm. And I'm going to talk next about Bacillus cereus because it's very similar to coag negative staph, which is, it's usually a contaminant. And just like coag negative staph, it may be real, particularly with CLABSI, and with Bacillus is often associated with IV drug users because they contaminate their paraphernalia. I just put up, just for Bacillus, just to remind you that it's really mostly a toxin mediated food poisoning. But that's not relevant. It's not associated with the bacteremia. So it's not relevant to this discussion. So really, if you've got a Bacillus, you remove the line, and usually vancomycin is just like with coag negative staph, which is 70% resistant to methicillin. You need to use vancomycin, and a short course is adequate. So obviously, if they've got more symptoms, you have to treat longer, but in general, a short course is adequate. So we can forget coag negative staph and B. cereus for the most part as being contaminants. Okay. So here's another infection that we don't see very often, and I bring it to your attention just to remind you that group A strep bacteremia is a usually a very horrible disease. It's usually associated with necrotizing infections. It can be with toxic shock. It's often pregnancy associated, just like group B strep agalactiae. So these are usually very fulminant and very serious infections. So when you see somebody who grows that, not only one, you're lucky that it's usually sensitive to penicillin. So group A strep doesn't have any resistance. So that's the good news, but it's overwhelming. The bioburden is huge. So we usually add clindamycin for at least the first 48 hours till you get down the bacterial load, and then complete a 2-week course. Because it is so sensitive, if they resolve well, then we can switch to oral treatment. But I just wanted to remind you that if you ever see a group A strep pyogenes, it's usually in the setting of fulminant disease, and use clindamycin. And we also, just a reminder that we use droplet precautions, because group A strep is usually carried in the pharynx and is highly contagious, but again, easily eradicated. Okay. And just a little word on clindamycin, because we use it for synergy for toxin, all these toxin-mediated illnesses. So we're using it really to, when we're worried about a large inoculum. So that's when we use it for necrotizing skin and soft tissue infections. It suppresses toxin, which is why we use it for TSS. And it has a long post-antibiotic effect, and may also suppress synthesis of penicillin binding proteins. So there are a couple of mechanisms, ways in which it helps, and linezolid has a similar mechanism, so it can be used if for whatever reason you can't use clindamycin. So just keep that in mind. Okay. So pneumococcal bacteremia, I think really what I want to highlight here is that HIV is independently associated with a worse outcome, with more invasive pneumococcal disease. So that anybody who comes in with pneumococcal bacteremia should be evaluated to see if they have it. I mean, we've got our usual risk factors, alcohol, debility, et cetera, but HIV is also strongly associated with pneumococcal invasive infections. And actually all HIV patients should be vaccinated. The other thing that I wanted to mention is a lot of people who, especially older people who come in with pneumococcal bacteremia, they really may be very ill. They may be obtunded. It may all be toxic metabolic, but if you can't rule out meningitis right away, then obviously you need to cover with dual therapy, and we need to treat with vanco and with high dose ceftriaxone, pending an LP. Usually 10 to 14 days is enough. Okay, so next, I'm not sure who was up at St. Luke's. We just recently had a case of an elderly woman with Listeria bacteremia. So it's usually seen in people with some kind of immunocompromising condition. It can be a marker for a malignancy. We tend to think of it in lupus patients and in pregnancy. And again, as was the case with the patient in the ICU recently, she was encephalopathic, and an LP couldn't be done because she was also coagulopathic. So we couldn't rule out CNS, but we had to assume that she probably had meningitis as well as bacteremia. So in general, you do 2-drug therapy, ampicillin or gentamicin. If you can't use gentamicin when a patient is pregnant, or as in this particular patient, she had AKI, then you could consider using ampicillin plus Bactrim. So Bactrim has excellent activity also for Listeria and is a good drug. And then the duration of treatment is quite long, a minimum of 2 weeks and up to 3 weeks if they're immunocompromised. And again, you need to rule out CNS involvement, which may require longer therapy. Okay, so finally, those are kind of, we're going to get a few more gram positives, but I'm giving you a break, and we'll talk a little bit about gram negatives. So gram-negative bacteremia, we used to, I guess, in the early antibiotic from the 1940s up until the 1990s, there really were a limited number of antibiotics, and people used to die of gram-negative bacteremia more often, and it was associated with endotoxic shock, and it was kind of the thing that we worried about. Around the late 80s and early 90s, there were all of these cephalosporins were developed, more broad spectrum penicillins, zosins, timentin, all of these drugs were developed only at that time. And so we had much better control of gram-negative bacteremias, and also surgical techniques improved. So we really have less worry now about gram-negative bacteremias than we do about gram-positives. So, usually with a gram-negative, where it's coming from, right? So this is our intermittent bacteremia with a localizing sign. They either have a UTI, if they've got a VAP, if the biliary system is involved. The few times where it's maybe a little bit more subtle is in, neutropenic patients, splenectomized patients who can get like a spontaneous SBP or a spontaneous bacteremia, and sometimes a catheter, a central line. There may be fever, but no exit site infection that is obvious. So otherwise, gram-negatives, we kind of know where they come from, and we can identify it. And therefore, if we can identify it, we can usually control it. Okay. So I think I mentioned that. So I think the point I was trying to make here is that critically ill patients, it's usually their gram-negative bacteremia is usually coming from a respiratory source or a catheter. But in our nursing home patients, which I think you are familiar with, it's usually a UTI. GI tract, biliary tract, skin and soft tissue are less common sources of gram-negative bacteremias, but clearly we do have cholangitis patients. Okay. So really for gram-negatives, we base our treatment on sensitivity. I actually realize as I'm talking to you now, I didn't mention that we have the spice organisms, which tend to, even if they say that they're sensitive, so spice organisms are the Serratia, Providencia, indole, positive Proteus, Pseudomonas, Acinetobacter, and increasingly Morganella. Those organisms, even if they say they're sensitive to ceftriaxone, will develop resistance on treatment. So if we're going to have to treat them for more than 5 days, it would not be a good idea, or 5 to 7 days. It would be better to up it. But otherwise, you just go straight with the sensitivity profile. We know that Pseudomonas you need to up to a cefepime or Zosyn. And for ESBL, we go to a carbapenem. I'll just mention, because I don't think, we're very fortunate that our antimicrobial stewardship is good. We have a pretty clean ICU and a population that really doesn't have Pseudomonas, and not really drug-resistant Pseudomonas when we do have it. So generally for Pseudomonas, monotherapy is adequate. And there's a lot of literature, I don't know whether or not it's still being discussed anymore, about whether you need 1 drug or 2 drugs for Pseudomonas. But in general, unless the patient is very immunosuppressed or they've got a history of drug resistance, monotherapy is adequate. If we are concerned, then we add an aminoglycoside or a quinolone. The problem with aminoglycosides is AKI. The quinolones, the problem is that there was so much use of quinolones that if it's not often adding much. If it's going to be resistant to cefepime, it's probably going to be resistant to a quinolone. So you're not getting that much out of your quinolone. So I think if somebody is really sick, it's worth giving them the aminoglycoside. pending the culture. And one dose of an aminoglycoside is not going to make or break their kidney function. And again, I will just say that when they're that sick, we add vancomycin, even if we are concerned about Pseudomonas. Again, the duration is short. I mean, depending on what we're treating, 7 to 14 days is usually adequate, because we usually have a focus that we know. And so the duration is not the problem here. Okay. So here are two reference articles for you. And this is what we had mentioned at the beginning. When do you do repeat cultures? So, we've said that we do it for sure for staph, but for gram negatives, these two studies and other studies have shown that the incidence of persistent bacteremia in here was 6%, compared to 21% for gram positives. And I actually rather liked their conclusion, which is follow-up blood cultures added little value in the management of gram-negative bacteremia. So it increases health costs, longer hospital stays, unnecessary complications, and use of antibiotics. So really, if they have a persistent fever, it's not unreasonable, but probably what's going on is you don't have source control. They've got an abscess. So generally speaking, I would say get a CAT scan, make sure it's not, with pyelo, make sure it's not a renal abscess. If it's cholangitis, maybe it wasn't drained adequately. If it's peritonitis or another intra-abdominal abscess, it probably needs IR drainage. So usually the failure for response in gram-negative bacteremia is almost always lack of source control. I mean, that's true for actually gram-positives as well, but with the lines. But this I think kind of may give you a little encouragement not to repeat. Okay, and next. Anaerobes, I just want to, I think we kind of dismiss anaerobes in some ways. One, because we don't see it too often, and generally because they are not they don't have endotoxin. They're usually not as fulminant. But B. frag, which is the most common anaerobe in the blood, has a significant morbidity and mortality. So it needs to be treated, and Flagyl remains the drug of choice. We can use Unison and Zosyn, have good anaerobic activities. The carbapenems have excellent anaerobic activities, but by far and away, Flagyl is our preferred drug. And Cutibacteria technically is an anaerobe, but it's a gram-positive anaerobe, and I just is sensitive to vanco, and really only is seen as a shoulder prosthetic joint infection. So those are a general comment on anaerobes. And then our next one is one that we all enjoy because it's young and healthy people, and we hope to make them healthy again. And we have seen maybe once a year or every other year, we usually see a young kid that comes in with septic thrombophlebitis of the internal jugular vein. And that's Lemierre's syndrome, and that's really the major disease association with Fusobacterium, and is really one of the few times we see it. And I just wanted to remind you of that. Again, Flagyl is, it's an anaerobe, so Flagyl works. But oftentimes, because it usually comes from the oropharynx, we worry about strep as well. We use Unison or ertapenem just because that's easy outpatient daily dosing. But it's a long-term, because it involves thrombophlebitis, it's a long-term treatment. And they can be quite sick. So just to remind you of Fusobacterium, the Lemierre's syndrome. Okay. And then we're going to round it out with, we're finishing up, but we'll round it out with the classic association of bacteremias, the strep and endocarditis historically, although we are seeing it far less now because people will get antibiotics earlier and it seems to be less of an infection. But streptococcus, especially strep viridans, were always associated with endocarditis. And this is a nice article where coming out of Denmark, where they looked at various strep species and they found that infectious endocarditis was pretty low for pneumococcus and for strep pyogenes, group A strep. But it increased in particular with the viridans group, and they have changed their name so many times. I've got it up there really just for you to recognize it, but Galeolyticus was formerly strep bovis, was group D strep. It's kind of a separate little group. That's the one that's associated with colon cancer. The rest are pretty much oral pharyngeal, but anywhere in the GI tract. So they're all associated, they have a high incidence of associated infective endocarditis. The only group, which again, I think this is a bit much, but I want you to just recognize the name, is the strep anginosus, which was the Milleri group, constellatus and intermedius. They are the ones, that the strep viridans group, that cause abscesses. So they're associated with intra-abdominal abscesses and less so with endocarditis. But the key point being, even with these, which we've said in general, unless we really have suspicion for endocarditis, they are very sensitive in general, or they respond well, and they will be treated, and we don't necessarily need to get a follow-up blood culture unless we think it's endocarditis. Okay, so the next slide. This is just a nice graphic form of the incidence of endocarditis. So we're seeing the mutants, Gordonii, strep sanguis. These are our typical strep viridans. They have a high incidence of endocarditis. Strep pneumonia is all the way down on the bottom right. Strep pyogenes, also very low incidence. You've got many more cases of bacteremia, but a very low incidence of endocarditis. Group B strep, slightly higher. So it just kind of gives you an idea of which bugs you have to worry about. So strep mutants, strep gordonii, strep sanguinus, there might be some concern and you might want to repeat. Okay. So this is, again, if you like these algorithms, it's a little, I'm not sure how well you see it if it's blown up big enough, but it basically gives you a scoring system. And I put this one in because it shows you with the strep bovis group that the incidence is higher with endocarditis as opposed to the anginosus group, for example. So it was a nice scoring system, but basically they say, do you have a heart murmur? Do you have one of the species that is more associated with endocarditis? How many blood cultures? How long have you been sick? Is it just one bacteria in the blood culture, and was it community acquired? If you've got more than 3, then probably you've got endocarditis. Let's go to the next one. So this was a little bit more readable. So if you're less than 2, don't do a TE. If you're more than 2, if you've got 3 points, then go for the TE. It's a likelihood that you've got endocarditis. And they're spelling it for British etiology. But I think the other way to remember it is if it's anginosis, which is that Miller-I group that causes abscesses, then it's probably not. So you get a -1 for that. So that's a nice, I think, you know, at least it's a helpful algorithm. And last is enterococcal bacteremia, which I mentioned briefly at the beginning. You know, some people defer treating if it's just one blood culture, one bottle, and they really don't look sick. And you just treat, usually if it's in a mixed infection, you don't necessarily have to direct your treatment against it. But if it is, you know, if it is a real pathogen, if you have positive blood cultures and it's the only organism, and it seems to be uncomplicated, then a week is fine. But as I mentioned, community-acquired enterococcal bacteremia without a primary focus has just recently, I think in 2020, been added to the modified Duke's criteria as a major criteria for endocarditis. So it's mostly because our population is also getting, I guess the immune system is down. There's an association, there may be an association with colon cancer. So that's another consideration. It's not a formal recommendation as it is for Galolyticus or what was known as strep bovis, that if you see that bacteria, you should get a colonoscopy, but there is increasingly a concern that enterococcal bacteremia may be a marker for colon cancer. And again, we usually treat with, if it's a serious infection, we usually do combination with AMP and ceftriaxone that spares the kidneys, or AMP and gentamicin. And here, the next slide is the de novo score is useful. So how do you decide if they've got complicated or uncomplicated enterococcal bacteremia? And this is D for duration, E, are there any emboli? If their number of positive cultures is greater than 2. Most importantly, you know, most people have enterococcal bacteremia that's coming from the urinary tract. But, you know, if you don't know where the origin is, then that's suggestive of endocarditis. Do they have underlying valvular disease, and can you hear a murmur? So I think that's very useful also in terms of assessing who is going to end up having endocarditis and who needs an TEE. So next slide. So this is a nice kind of summary of the algorithms for the gram positives that we really worry about may have complications. So as I mentioned, most gram negatives and even most gram positives, other than staph, don't need follow-up blood cultures unless they're persistently unless they're persistently ill or bacteremic. And then these scoring systems can be helpful. So for entero, we're going to do the de novo score. For staph, we can use the Versta or Predict scores. And for strep, we can use the HANDOC. And they will be helpful. And so this is European Heart Journal. So I'm not sure where we are with time, but I think that's kind of my spiel.
That was very helpful, Dr. Stavropoulos. Thank you so much. We still do have a couple minutes. If anyone has any questions, you can feel free to unmute yourselves. I know that there's a lot of information covered.
Hi, I'm Tomo. I have a question.
Okay.
Hi, Dr. Stavropoulos. Thank you so much for the great, teaching slides. I really appreciate it. My question is, when do you start rifampin for IE patient?
So the use of rifampin is limited to only staph infections, and that is either or, or both, I guess is what I'm trying to say, Staph aureus or coag negative staph, because only staph can cause biofilm, and only rifampin penetrates biofilm well. So it's really with prosthetic devices, whether it's the heart or whether it's a joint, for Staph aureus only. So if you have strep endocarditis, rifampin's not doing anything for you. If you have enterococcal joint infection, rifampin's not doing anything for you. It has to be a prosthetic, and it has to be a staph.
Okay, thank you so much. I noticed that some doctors wait a few days before starting rifampin to avoid some resistance. So when do you start rifampin for IV?
The actual day, that's usually, you wait around 3 to 4 days. So, again, it's not a precise thing. The idea is that you can induce resistance if the bioburden is greater than 10 to the 9th. That's when mutations occur. So you hope to get that bacterial load down less than 10 to the 9th, and that usually takes a couple of days. It's arguable if you've removed the valve at surgery, I think you've lowered your bioburden, so you could probably start earlier. But the custom is you wait about 4 days.
Okay, thank you so much.
You're welcome.
Okay. If no one has any more questions, thank you again, Dr. Stavropoulos. That was a fantastic lecture.